Hello friends, myself is Kunal Chandra, presently working in KC's GMC Karnal as a prosthetist and orthotist and former assistant professor at SAMS Indore. Today I will discuss Clubfoot and its Ponseti management. Clubfoot, it is also called congenital talipes equinovirus, that is CTEV. It has main deformity that is cavus, adductus, virus, and equinus. Cavus is excreted uh, medial longitudinal arch, adductus, in which the forefoot turn inwards towards the medial sides, and in virus, that is also foot is inverted, and in equinus, foot goes in plantar flexion. So that will be the sequence of the deformity correction. Also, clubfoot deformity, subtalar joint of its extreme range of supination. In this diagram, you can see there is a subtalar joint at its extreme range of supination. So Ponseti method, Dr. Ponseti was very famous for the treatment of the clubfoot. Ponseti method was developed in 1950s and popularized in the 2000. It has excellent long-term results and relatively simple technique than surgical procedures. Now the question is why the Ponseti method of clubfoot correction works. Understanding of the kinematics of the tarsal bones and subtalar joints is necessary to understand this topic. The Ponseti method or technique is effective because it takes advantage of the kinematics of the subtalar joint. Well conducted, according to the Dr. Ponseti written a book, Congenital Clubfoot, Fundamental of Treatment. It quotes that a well-conducted orthopedic treatment based on a sound understanding of the functional anatomy of the foot and on the biological response of the young connective tissue and the bone can gradually reduce or almost eliminate these deformities in most clubfoot. A sound understanding of the functional anatomy of the foot is necessary to learn the treatment of the clubfoot. This in diagrams you can see the extreme supination position of the CTV foot or clubfoot. So principle number one is that almost all the motion of the foot occurs around the talus. And calcaneal motions like flexion, extension, abduction, adduction, eversion, and inversion. Almost all the motion of the foot occurs around the talus, that is ankle joint, where plantar flexion and dorsiflexion takes place at the talotubular joint, and talocalcaneal or subtalar joints, and talocalcaneal navicular joints, that is acetabulum pedis. And the second principle is calcaneopedis block. The entire forefoot moves with the calcaneus around the talus. One may consider the subtalar motion one between the talus and a fused group of tarsal beneath permitting simultaneous rotation at the talocalcaneal and the talonavicular articulation. So the correction of the rear foot and midfoot can be accomplished by adduction of the forefoot. Adduction pressure on the first metatarsal lever can motor movement of the calcaneus. And in this picture you can see the subtalar joint center of axis. Talocalcaneal interosseous ligaments and corresponds close to the ankle center of rotation. Anterior tibial tendon line of the pool is medial to the subtalar joint axis, causing inversion. Transferring lateral to axis causes eversion. This a Ponseti method of treating clubfoot deformity, adduction, inversion, flexion goes to the abduction, eversion, and extension. So these all the correction is done follows normal kinematics of the subtalar joint. In this diagrams, reduction of the talonavicular joints is shown. Here first we locate the head of the talus that is situated just distal and anterior to the lateral malleolus, you can see and feel and locate the head of the talus that act as the fulcrum during the correction of the foot during casting procedure also. And this is in the diagrams. This is the first cast of the club foot. Forefoot pronated on rear foot causes kyvus. Kyvus, that is exaggerated medial longitudinal arch. For correction of this kyvus, we just elevate the first ray. Elevate the first ray, but the foot looks worse, even more supinated. This is the picture of the first cast for correction of the kyvus. Correction occurs by allowing normal tarsal bone kinematics. This is the principle 4, and this dorsiflexion and plantar flexion takes place at the ankle joint, or that is tibio-talar joint, and pronation and supination takes at the subtalar joint. This is varus and valgus, here heel valgus. Now supination consists of, it combines inversion, adduction and plantar flexion along with heel varus. Heel goes in varus and supination. And just opposite, pronation, it consists of abduction, dorsiflexion and eversion, and heel goes in valgus. In this diagram, we can see if you are standing, then the heel goes in pronated position, but when we stand up on the tip toe, then this go into the varus of the heel. Now kinematic coupling, as the foot is abducted, the inversion, that is apparent supination, spontaneously corrects to neutral. The forefoot is never pronated, and without touching the calcaneus, the heel spontaneously comes out of the varus as the foot is abducted. So there again kinematic coupling occurs, and the heel spontaneously comes out of the varus as the foot is abducted. So abduction is so necessary, and this follows the normal kinematics of the subtalar joint for correction of the different deformity like adduction, inversion and flexion, that is equinus. Inversion and eversion are kinematically coupled to abduction also, and this is the kinematic coupling showing by the model of the skeleton, and this is elevation of the first ray to reduce the kyvus deformity, and this is the first cast of the for correction of the CTV. Eversion is kinematically coupled to abduction, and the foot is never pronated. Heel varus and the abduction are kinematically coupled, and dorsiflexion of the calcaneus through the subtalar joints and abduction are kinematically coupled. This is the final cast, generally around with 50-degree abduction just before tenotomy, and after tenotomy it goes to the 70-degree abduction. This results in the anterior process of the calcaneus comes out from the underneath of the talus, and it dorsiflexes into the sinus tarsi. Dorsiflexion of the subtalar joint is achieved by stretching the posterior capsule. The lateral tether is stretched, and full abduction of the foot is necessary to effectively treat the clubfoot. So why is the 70-degree of abduction necessary? It looks so abnormal, but the normal abduction of the foot is around 70 to 75-degree. So maximum abduction of the foot is necessary to restore the normal tylocalcaneal angles, is necessary for the calcaneus to come out of varus, is necessary to properly stretch the calcaneofibular ligament and lateral tether. It is also necessary to obtain dorsiflexion of the subtalar joint. As the foot is maximally abducted, the subtalar joint spontaneously extends and the dorsiflexion improves without rock or bottom risk. But the Dr. H. Kite made mistake. Dr. Kite was wrong because he did not understand the subtalar joint kinematics. He blocking the calcaneus from the abducting, causing iatrogenic deformation of the mid-tarsal bones and joints. This is the Kite's mistake, and that creates secondary deformities. And after correction of the different deformities like cavus, adductus, and the varus, and dorsiflexion up to 10-degree, then we go for the tenotomy for full range of dorsiflexion or percutaneous Achilles tenotomy. Foot is in 70-degree external rotation and 10-degree dorsiflexion, and cast should be always above knee. The final cast 70-degree abduction, final cast after tenotomy, and it remains for 3 weeks. Generally other cast we change weekly, and this final cast should be for 3 weeks, and after removing the final cast we go for bracing or foot abduction dressing. Maximum abduction, two most significant factors in preventing relapse is 70-degree abduction or more and long-term night abduction bracing, that for 4 years. And when the patient or child start walking, we go for CTV shoes for day also. And for knowing the severity of the deformity, we make a measurement scale, that is Pirani scoring, and it is 0 to 6 scale. It has curved lateral border, medial crease, talar head coverage, posterior crease, rigid equinus, and empty heel. So if it is 0, then normal, and moderate 0.5, and 1 for very severe deformity, and all the score is added, and that is reference for the deformity correction, and also to know the when the tenotomy is required. And after removing the final cast, we go for foot abduction brace, that is heel shoulder width apart and adjustable, open toe and open heel, external rotation 70 degree. This foot abduction brace is very important. Please don't underestimate the power of bracing, and use the bracing for maintenance of the correction. Otherwise, the foot again relapse and deformity again occurs. This is the a step is foot abduction brace, and abduction bar is bent outward so that the foot goes in the dorsiflexion. And these are the different foot abduction braces that was developed and used by the different professionals and artisans. In this picture, you can see the Dr. Ponseti. He is treating the patient or child. He is very famous for correcting and making change in the life of the many children with the Clubfoot. Thank you very much for Fashions Learning.